Hello, I'm Kathy Chester, and this is Move It or Lose It, a podcast about all things that move the mind, body, spirit, and soul.
Okay, here we are. Welcome to another edition of Move It or Lose It. Today, our guest is Erin Glace, and I'm so excited to have her on because we are going to get down and dirty with all things about the pelvic floor and all things about physical therapy. So, welcome, Erin.
Thank you. Thank you. I'm excited to be here. I really am.
So am I. And so are many that have been anxious to have a better understanding as to what it is that you do and how you can help us. So a little bit about you. Your undergrad was University of Florida, Bachelor's of Science in Physical Therapy. Then you went on to graduate Old Dominion University, Master's of Science in Physical Therapy. So the bachelor wasn't enough. So then you got a master's and then certifications in PRPC, pelvic rehabilitation. So you're a practitioner for that. Certification in BCB, PMD.
Right.
Okay. I'm going to try to sound intelligent, like I know what that is. But I'll let you explain.
Right. I've been practicing for a long time. So I've had a lot of time to take a lot of courses and sit for exams. And so basically that just means that I really love treating people who have pelvic health problems. And so it's kind of been my journey to continue to learn about how I can help patients who have pelvic floor problems.
So how long have you been at the University of Virginia?
It's actually urology of
urology, yes.
UVA. So oftentimes people mistake that for UVA, University Urology of Virginia. We're in the Hampton Roads area of Virginia. So I live in Chesapeake. We are locations in Chesapeake and Virginia. I've been with Urology of Virginia for about 21 years.
Wow. Okay.
But yeah, so I've been.
Well, you must really love it, obviously.
I do very much. So I love the type of patients that I see. It's a very underserved population, I would say. Fortunately, though, we have had the emergence of probably the last 5 to 10 years. We've really seen a kind of an explosion of therapists who are interested in pelvic health. So
thank God.
Exactly. I'm so thankful to have colleagues and young women working with me, and it's been great to see the evolution of the practice.
Yeah. So Erin, when you went into physical therapy, what was it that drew you into learning more about pelvic floor issues? What brought you into wanting to learn more about that?
Right. Well, interestingly, when I graduated with my bachelor's degree and then kind of pursued my master's degree, I was really interested in pediatrics. So really took a turn. I had a friend who was interested in starting a private practice. We did a private practice. She had a friend who was an OBGYN who said, hey, I would love to send some of my female patients who have stress incontinence after they have babies. So that was kind of our tiptoeing into it. We were in a private practice, and at the time we were just trying to grow the practice, right? That's all that it was. We'll just grow it in this way, but I'm going to keep doing my kiddos. We had school system facts, all of that type of stuff. And then I started seeing the patients, and it just blew my mind. And, as a physical therapist, seeing how people really didn't understand how muscles could help and how really the physical structure of the body was just kind of ignored when it came to bladder symptoms and pelvic pain, pain, these things that's really not talked about.
Explain a little bit more about that, because I read about that and I thought, I wonder how many people don't know what pelvic pain is.
Right.
One of those things you don't know until you know. So
Exactly. So the the source of pelvic pain, and if let's just talk about women, right? So
Mhm.
the source of pelvic pain for women it can come from a lot of different areas, but unfortunately it's not readily identified when it is a musculoskeletal condition. So, women are we very much identify if I have pain in my lower abdomen above my bone, I'm going to think bladder, I'm going to think ovaries, I'm going to think
Right.
of things that might be driving the pain. And in some cases, that could be the case.
Mhm.
But unfortunately, women have for many years had say, oh, I have this pain, and they go to see their primary care provider, which is, their primary, not to diss primary care provider,
Right.
that
Right.
or their GYN that says, well, I'm not seeing anything wrong with you, so
Right.
I'm not have this pain. Well, there's a lot of muscles, there's a lot of nerves. So you can have pain in that area that feels as if it's coming from the bladder or the
Sure.
and it's actually coming from the musculoskeletal structure, the pelvic floor, abdominal muscles. So those women, unfortunately, are very much kind of shunned, or like, oh, well,
Right.
wrong with you. It must just be you. So
Right.
sorry.
So a little bit before that we were able to chat before, I had told you a story that we've been doing a lot of bringing on doctors during the month of March, being MS Awareness Month. And I told you a story that having MS for over 20 years, going to different urologists, I've had a lot of with MS, it's really attacked my kidneys and having a lot of urinary tract infections. So I remember going in and the doctors would constantly tell me that, well, you've had 3 children. So of course there's going to be some leakage. And I would constantly say, well, no, it's not like my friends that have had kids. I'm not jumping on the trampoline. And, I would understand that I couldn't maybe jump high and do somersaults on the trampoline, but this is different. I am getting up from somewhere. I'm getting up from, let's say, watching a show with my friends. And all of a sudden I didn't feel I had to pee, and then it's there. And so it was a lot of being shoved aside. And even a regular urologist didn't understand and would just say, you've had 3 children, so there might be some limitations, and would constantly want to, if they did see me, would want to go to surgery. And I would be like, whoa, wait, like, is there anything else?
Oh, right. Stop. Is there a step before that? So I think, yeah. So I'm going to say a couple of things. One is that if my neck's not red, it should be. Well, you've had 3 children, so what do you expect?
Right.
Well, I expect more than that, because the reality is there is treatment for women who, regardless of having the diagnosis of MS, if you just had 3 children and you went in and said, I am leaking, you've had 3 children is not a good answer. It's like, hey, that's a part of the picture. That is part of what's going on with you. Yes, that's great. It's fantastic. And you should be like applauded for bringing 3 human beings into the world, right?
Instead, it was almost like it's like, well, you had 3 vaginal births. So I'm like, isn't that good? Isn't that like a plus that I did that? Like, yay. And I didn't have an epidural. That might've been nuts, but I did it. And so
so that's not a good answer, because we do know that there is care for, and we can treat women effectively with pelvic floor physical therapy, with exercise, with behavioral modifications. So when you look at the different types of incontinence that are out there, we can designate based on your symptoms that you present with, we can talk about the different types of incontinence. So stress incontinence is what you were talking about. It's like, okay, well, sure, I can't jump on a trampoline or cough or sneeze, which of course we want to teach you ways that you can do those things that you can't want to do. That's stress incontinence. And stress incontinence means that there's a pressure down on the bladder that the pelvic floor muscles, or the urethra, the tube that comes out of the bladder, cannot protect against that downward force. Sometimes that is related to pelvic floor muscle weakness, which also can be related to vaginal childbirth. Okay. Or it can also be just being pregnant. You could have had a C-section and still have pelvic floor. So that is stress incontinence. So that is something where we know literature supports that pelvic floor exercises 100% should be the first line of care for that. Right.
So question for you with that. Now, let's say my children are already grown. Now, is there a time that it's too late to do it?
No.
Okay.
No.
Because I know I'll have questions about that.
Right. With straight up stress incontinence, there is not a time that it's too late to do that. Always, in my mind, always should be the first line of care should be pelvic floor or learning how to do these exercises. Unfortunately, it's not super accessible for a lot of people. So there are ways, you at this point, you can kind of Google pelvic floor physical therapy. But if you don't know to Google pelvic floor physical therapy near me, you don't know to find that. So just that kind of Google search right there can lead you in those directions. So stress incontinence is a type of bladder leakage that is common amongst women who have had children. It's also common amongst women as we get older because we know we lose muscle mass.
Right.
So just like any other, and you're a fitness expert, right? So we know that especially as we get a little older, weightlifting, exercise becomes important.
Absolutely.
Pelvic floor exercises or incorporating that into your program often is dismissed, right? We don't even think about it. So you can train those muscles just like you can train your biceps muscle, right? So very important to do that.
And what's weird, Erin, what always didn't make sense to me is from very early on with multiple sclerosis, even when I was told to go home and rest, back in the day when you were given the brochures, just rest. It never made sense to me with all of my training and coaching and sports but my muscles will atrophy. This doesn't make sense. And so the same intuition, I felt the same way about what was happening down there. This doesn't make sense. There are muscles down there. They need to be worked. And so all I can say is I've been Kegeling for a lot of years and it's just hasn't. So yes, that.
Right. So that is where we get into this, the idea of, that the Kegel is the answer to everything because it's not.
Exactly.
Right. Just like when physical therapy, we are exercise specialists, but we are functional motor. Like, how does your body work and how can we help you through therapeutic exercise or through behavioral modifications, through education, through, even dietary changes. That's kind of the physical therapist realm should be functional motor.
Right.
Sometimes and I wouldn't want to say just doing a Kegel because yay, Kegels. It's like, yay. But Kegels may not be the answer for everyone clearly, because that's what you've experienced. Like, okay, I've done ever. Kegels aren't the answer. Totally get that. And what we need to know then is that's especially when you need to see a pelvic floor specialist, right? Because okay, it's not the Kegel, but ideally, and because I have been very fortunate to work for so many years in a urology practice where I understand the complexities of the urological system. We know some different ways, and there are other modalities and tools that we can use to help patients who have other types of bladder problems. So you have stress incontinence, you have urge incontinence, and I have to really assess, kind of do the nuances of come in to me as a patient and ask you all the questions and assess your pelvic floor to kind of really delineate what type of incontinence you have. But urge incontinence is that type of incontinence where I'm sitting and I'm chatting and all of a sudden it's like, oh, I really got to go to the bathroom. And normally we would think, okay, I'm going to get up and I'm going to walk to the bathroom. But you get up and you're just
Yes.
incontinence is this, like, I cough, I sneeze, I jump, I put that pressure down. Urge incontinence is gotta go, I get up and I cannot make it to the bathroom.
Yes.
So that has a lot to do, again, with the bladder overpowering the pelvic floor,
Okay.
but also the bladder just having too much push pressure,
Okay.
too much sensory input, and it just pushes too hard, versus just like a pressure, a quick push down for the stress incontinence. This is the bladder actually going, I'm going to go right now. Right.
So what causes, and this may be too big of a question, but what causes the bladder to be that forceful?
Yeah, that forceful. So it can be neurological, right? It can be that there's signals from the brain, from the nervous system, hello MS, that are giving us too much signal.
Right.
To it can be, but a lot of times it happens with age. Overactive bladder can also occur from just too many bladder irritants. So if I drink too much coffee and not enough water, my bladder is going to be kind of like angry, and it's just going to kind of everything out. Very similarly to if we eat something that disagrees with our stomach, we know, we better run.
Right. Yeah.
So that's urge incontinence. You also have what we call overflow incontinence, which means that the bladder doesn't really completely fully empty, which can lead to, unfortunately, more urinary tract infections.
Right.
Because if you're not completely emptying the bladder, then the urine stays in the bladder, and it unfortunately can become like a breeding ground for bacteria if you're not kind of getting that out, kind of flushing the bladder.
Right.
And then also if it's too big, too much volume, then any kind of movement kind of pushes that out, and it overpowers that sphincter connection, the bladder holding connection.
That makes sense.
Right. And so urge incontinence or overflow incontinence, that's where like a really good assessment can help to determine what that is. And then that drives the treatment.
So what would you do? Like, I know a lot of the MS clients, patients that I see, a lot of times will have all three of them. They'll have the pushing, I don't know, I had to go, and then all of a sudden I went. They'll have, I've done this so many times through the years where all of a sudden I have to go, and then there's no time in between. It's like I have a 2-second window, and if I don't get to the bathroom immediately, it's done. So, and then there's the leaking where you think you're done, and then it's, you're trailing as you walk. So a lot of times, I don't know if this is just with an autoimmune with MS, is it common that a lot of times a person could have all three?
No, yes. So it's not uncommon. The overflow incontinence is pretty rare. That is involved in most often, either for women, it's most often going to be like a neurological condition. Men, because their prostate sometimes can get a really overdistended bladder. Right? That is a separate conversation. I know that men have MS and men have the same.
Yeah.
Bladder.
And
So,
I do want to touch on that, because when I was going over your stuff, I don't think that many of us think about men when we think about pelvic floor. And I thought, we do need to discuss that, because so many of my MS clients have really enlightened me on that. And I thought, I apologize. I never thought about men in this area.
Oh, yeah, absolutely. Men are, they're half of my patient load. So yes, and men, unfortunately, equal opportunity, they can have bladder issues as well. And it can be like derived from like a neurological source, or it can be, unfortunately, it's often multifactorial. So when you asked about having like both of those or all of, we kind of just lump that into a diagnosis of you have mixed urinary incontinence, right?
Right.
So
right.
Stress, urge, sometimes overflow, even though that's a little less common. And then we just say, okay, well, it's kind of both. So we'll put the title mixed on it, right?
Okay.
Urinary incontinence, and that's people can have that regardless of any type of neurological or autoimmune diagnosis, mixed urinary incontinence occurs. So when you talk about men or women, you also have to consider the fact that it's not typically one thing that causes it. There are cases with MS for sure that MS is unfortunately wreaking havoc on the bladder system, and we very clearly attribute those symptoms to the MS. But Kathy, oftentimes it would be somebody like you, if we're using, because you're using yourself graciously, very graciously as an example, you have had some children. So we know that perhaps there is some muscle weakness. So it could be partly due to that.
Sure.
Could be partly due to maybe some incomplete bladder emptying. That could be because you're also very fit and athletic. And we do see sometimes with our athletes that there tends to be a higher tone or tension in the pelvic floor. And that in some cases can create a dysfunctional voiding where you don't release, which could have to do with just those lifestyle factors.
Yeah, sure.
But then when we have MS, we have to be aware that there is a possibility that MS is contributing. So for women, it can be very much multifactorial. So for your male clients, it's the same thing, right? So is it the MS? Is it the fact that maybe depending on their age, there's some prostate hypertrophy? So if the prostate is bigger, then that can create some bladder issues. Or it could be the pelvic floor. It could be if you're a very fit, active man, or if for some reason you've created a muscular kind of tension that can also create problems.
Sure.
So, I know I'm saying a lot, but
no, it's great.
The basic premise of that is that oftentimes it's multifactorial. It's not just one thing that contributes. And that is where having somebody who can kind of look at you as the total person and say, how is your body functioning? What are you doing? The behavioral aspect, what are you putting in your body? How often are you going to the bathroom? How much are you going to the bathroom? All of those things.
Yeah. I love that. And I think that's, just talking to different, actually nurses have been a big help. And as far as like helping me to know when to stop, the coffee, how much coffee, things like that, which has helped a lot, but, just getting little tips and things like that through the years. But it's been amazing to me just not having as much here in Michigan, we really have had to develop our own team here, where when I have driven throughout the last couple of years, trying to figure out what I was going to do with some different MS issues that I was having, finding in different areas, you have a whole team set up. If I was going to go to the Cleveland Clinic, there's a whole team. And then coming back to Michigan, it was like, there's no team. We have to find our own. And it was very interesting going to Cleveland because I was like, wait, you have specific people that work with pelvic floor. You've got therapists that do that. You've got therapists that work, you've got neuropsychologists, stuff that we just don't have here unless I was living right in Ann Arbor by the University of Michigan, which I wouldn't mind that, but that's not where I am. So I found it to be very tricky when you're not in an area where all of that, where you have a team. You really have to be very assertive in finding your team and finding what it is that you need in a world where you're not really sure what it is that you need. And
that's why it's so awesome that you and, our mutual other
absolutely
are such strong advocates. And that's why I'm like, absolutely, I will talk to you anytime, because
thank you.
We need to have these conversations, and, people, your audience needs to know that, oh, wow, I'm having these problems and I don't want to have surgery. And this medication is making me, so I don't want to keep taking it. And I'm not sure it's working anyway. And, pelvic floor physical therapists. And sometimes, just like any other healthcare provider, it's like, sometimes you're going to mix with somebody, mesh with somebody, and sometimes not. So you just kind of keep that search, keep looking. it is unfortunate with so many of our medical conditions and so many of our different areas. You know, if you don't live in a big urban area, has all these resources. I guess that's where the internet is such a great thing.
Oh, for sure. And I would say too, I'll ask you for any input and I'll put them at the bottom of the show notes, any referrals that you have in different areas. And for sure. And, you know, I've asked if you come to Michigan or I'll come to you, but we'll see. But no, so I want to kind of switch a little bit because I want to talk about, you can't see it here. I want to talk about your book. Wait, there you go.
Oh,
there you go. So let's talk about your book that you wrote with our dear friend, Kathy Reagan. So
right.
Your bowel and bladder issues in multiple sclerosis by two pea brains with potty mouths talking shit about MS. So how did that come to be? I love it, love it, love it.
So I will tell you exactly how that came to be. Kathy and I were sitting, I think in Panera, and we were chatting and she said something to me, and we were already dear friends. We were already great friends. And you know how you have some friends that it's just like you do your life together and you're just like so much about life, and we have little kids and we were just all about life, that she knew I was a pelvic floor physical therapist. I knew what she did, and we all of these things. But she asked me some questions. She said, Erin, I'm having some issue. And I just started like, okay, well, let's talk about, this and that. And, your pelvic floor is bowel, bladder, and sexual function. So all the things you want to talk about in Panera,
right?
A little table when we're having a girls' time, right?
Yes.
Saying all of these things and asking her all of these questions, and
you just needed some wine, and then it would have been perfect.
Right, exactly. Well, we've done that since.
Yes.
But she was just kind of mind blown. And Kathy, I'm going to tell you that what I just told you is supported by literature, and that, I'm not at the point where I can tell you, okay, these guys are the people that did it in 1999 or anything like that. But I do want to be very science and kind of factually based on what I do. And Kathy's just a smart ass. Right. So,
oh yeah,
we combined that, and and she just made it funny, and we tried, and because she just was like, this is crazy that people don't know this kind of stuff.
Yeah.
So
it is. It's nuts.
I credit her 100% for us, because she said we need to put this out there, and it's it's
how much fun did you guys have?
Oh, incredible. I would write as Kathy says, my smart thinky stuff. And then she would add the funny kind of,
yes, her smart ass stuff.
Ass, right?
She's so funny. I remember when I did my first podcast interview with her, and she had asked me what my goals were. And it was a very serious question. I said, well, to be better than you. I don't want you to be better than me. I want to be the best podcaster. And she just laughed. And I thought, at that moment, I was like, I love her. Like I could truly be good friends with this woman. And she's been, you know her, you love her. And she's just inspirational and funny. And I know I can email her quick and say, help, or, whatever. And I just love that about her. So the book has been great. What feedback have you gotten from the book?
Just that people are thankful that the information is out there, and that, we have put together a resource for some things that people can do to help themselves. I think that's what it is. And it's, it's definitely, I had hoped that also it would be a starting point for conversation, so that I think as a consumer of healthcare, if you can go to your physician and say, I think that I have urge incontinence because these are my symptoms.
Right.
And, I would like you to consider, this or that, or a referral to a pelvic floor physical therapist. Some insurances do require a referral.
Mhm.
Some therapists, some states, all of our states are different. Some states you can directly call the PT and say, hey, I want to come see you. They're like, great.
Right.
Others are like, no, we need to pursue a physician prescription. And usually the therapy places will help you to get that. But not always. Sometimes you have to go through your physician. So I think just as a point of education, tips and tricks to try. And then also here's some knowledge. And so that you can go in and be an educated consumer and have some language to request, because sometimes you get, 11 minutes.
Right. Exactly.
Right.
And you're trying to remember all that stuff. And I cannot tell you, before I started writing it in my notes, how many times I would leave and think, I forgot 5 things I needed to ask. And then it's hard to get back in touch, and you're playing phone tag and trying to get back and ask those questions. And so you're right. It is. I thought it was a great idea to have those tips in there to get the conversation started and to ask those. And I think it is something that I find still, especially with our newer diagnosed patients, it's embarrassing, especially when they're in their 20s and 30s and they're looking at this like, I don't want to talk about this. I don't want to, until they see someone like Kathy or myself that we're older, but we're not decrepit. We're not like looking like her, and we're able to do things. We're able to teach others. We are fit, and we're, how much Kathy loves to exercise with me. So, but she just ran. So that was awesome. So I think that when they see people talking about it more often, then it becomes something that's not so taboo, nor should it ever have been. But they feel more at liberty to discuss these things with their doctor and to be able to ask. And if they're not getting that, then for goodness sakes, to be able to email someone like you and say, help, because no one's giving me an answer. I'm not getting an answer.
Right. Exactly. And, the fact that it's taboo, it bothers me so much, because, so many things that we can talk about, but yet we attach shame to this. And it's like, we don't need any more shame in this world. We do not. And, shame that's attached to any type of bodily function that you really don't have any control.
Right.
And then sometimes you just want help, I just want help for this. And, but how do I say that? Or, if you're blown off by a practitioner, that's the thing. It's like, if you're blown off by a practitioner, then you have to ask the next one again.
Right. I remember even in my early, I want to say 30s, and I was going on a run, and I had just a cute pair of light blue shorts on. Hadn't had any, urinary issues yet. Was on a run. Out of nowhere, I soaked my shorts. I was with a bunch of runners. There was no denying what happened. Most of them didn't even know I had multiple sclerosis. So it was incredibly embarrassing. I had no way to hide it. I didn't have a shirt to tie around me. It was there. I had peed, and there was nothing I could do to hide that. And so I can relate to so many. And I often share that with my younger clients, that I understand that embarrassment, and you'll get through that. But to push it aside and to not get the help you need is worse than anything. To just pretend it never happened or it's not happening is worse than just going and swallowing that nervousness and asking for help.
100%. And, I think the perspective that I often try to give my patients is, in that run, if you had sprained your ankle, would you have been embarrassed? Probably not. You would have been, I hit a rock, or there was something, or there was some oil I hit and I, slipped. Obviously nobody loves to fall or sprain anything, but it's the same type of embarrassment. Or if your ankle was weak, your ankle, and somehow it's like it kind of slipped out, or you had a knee injury, or you pulled your hamstring, some type of musculoskeletal kind of injury, or okay, it didn't work right at that moment, right? My hamstring didn't work right at that moment, and I got like a really strong cramp. You push through and you go, and you're like, oh wow, yeah. But you had the bladder, the pelvic floor muscles that didn't that moment, and we're like, oh, the shame.
Right. It's ridiculous when you really break it down.
It's not ridiculous, because that is the way that our culture has kind of made it.
Yeah.
It is anything that has to do with down below is become shame versus like, oh, what can we do to help you?
Yes.
Muscles, this is your body. And that means that you go to the correct specialist to kind of help you to figure out how to handle it.
Absolutely.
Right. That is why all those years ago, I went from pediatrics to pelvic floor, because I was like, somebody has to talk about this.
Yes.
And I have no problem. I will talk poo, pee, sex all day long with anybody. You need to know how it works. Just talk to me. Let's do it. So,
and I may be asking you to do every, once a month, I have women on, and we do a wind down Wednesday. And I have women on. Last night I had, Dr. Megan Meyer, and she, and what we did with her is she is a neuropsychologist. And so she talked about the different anxiety, depression, and things that our MS community goes through, and how we can't quite, figure out like, where's the depression, where's the anxiety, and that kind of stuff. So I would love to have you on and talking with the women. And we've got some real powerhouse women that just kind of come on and share from their perspective. And then it really opens up a lot of the MS women to say, oh, well, they talked about it, so it's okay. I can make a phone call. I can do this. So it is, again, it's just that opening up, spreading awareness, and looking into, and that's really my heart's desire, is to spread awareness and bring just that understanding to so many of women and men dealing with this, that there is more, and we can have a full life, but we have to be willing to look in and ask the questions. And so, Erin, finding you was so exciting, because it's something I know so many of us deal with, and yet there is this shame attached with it, and there shouldn't be. But so for us that want to be able to see someone with like you, and I may not want to Google it, but I want to come and see you in Virginia. So so then, is that something, do you have openings if someone's in Virginia and they want to look you up? They can just do that. And
if they're in Virginia, I'm with Urology of Virginia, and they absolutely can. As far as traveling to see me, I would say you probably could find somebody closer.
Yeah, no, I know. I'm teasing you. No, it'll probably be University of Michigan is probably where I would find, I think. So I'll look into that. There was one, like I told you, I went to, and the first thing out of his mouth was surgery. And I just said, thank you. I'll go ahead and leave, but thank you.
Right. And that's where you want to look at pelvic floor physical therapist. So it's not in a pelvic floor PT's scope of practice to prescribe medication. So you're not going to come in and have us, say, well, here, let me just write you a prescription, and I'll see you in, 6 months and see how you're doing.
Right.
And it's not in our scope of practice clearly to do surgery. So you're going to have somebody who's going to talk to you about things that you can do. And, when you look at the AUA, American Urological Association guidelines for so many of these issues that MSers are experiencing, women are experiencing, pelvic floor exercises, it might not say specifically pelvic floor PT, but it will say behavioral changes, pelvic floor exercises. And that's what you're going to get from your pelvic floor PT. You're going to get somebody who says, let's look at what you're doing right now, and let's see how things that we can help you to do can change. And it can be incredibly impactful. And typically, so if I see a patient that, unfortunately I can't help, then we talk to them, then I will talk to them about okay, here's what you can expect for your next steps. Right. And these are that you can try. So, I think every woman postpartum should have a pelvic exam and yearly, like, how you doing? Let's keep you going.
Yes.
Let's surgery in the future. Let's, keep you active.
I love that. I love that you said it that way, because I think oftentimes, every time I've been sent to a urologist with all of the infections and things like that, never have I been sent to a pelvic floor therapist or anything like that. So
Right.
I find it so interesting, and I'm going to have this on the bottom of the show notes, but I really want listeners to hear that when they're asking and looking for the right things.
Right.
And because you'll be sent to urologists, not that that's a bad thing, but make sure that you're looking at all aspects, that you're not going right into surgery, that you're really looking at the issues that are underlying before you're going there.
Right. Exactly. I mean, as a first line of care, unfortunately, surgery can be necessary, and surgery in some cases is the first line of care. But it depends. And if you're not ready, then you should be offered. And I'm not sure that surgery is the best option when you're talking about specific types. It's not for specific types of.
Sure.
Yes.
No, I love that. And I think this is so enlightening, and just, tip of the iceberg for so many that don't understand this and don't know there's another option. And I know for me, I was like, wait, I have another option. And so it really peaked. I think that the one appointment I could get in is 6 months from now to see. I was like, so I'm hoping to get in with someone else before then. Yeah. So it's backed up here.
Yeah.
Now, last question I have for you before we move on is, what have you seen since COVID? Have you seen a bigger number of patients coming in? Have you seen it grow, or what have you seen?
So I would say that as far as COVID impact on the diagnoses, I've had maybe one or two people that felt that it was an impact. I have one beautiful woman that I'm working with right now who has long COVID symptoms, and she's with pelvic pain kind of thing. So I've had another that said they had kind of some transient issues post-COVID, but I have not personally seen a lot of people that are attributing specific new symptoms to COVID.
Good. Any patients that have been more nervous to come and see you, or just to go because?
Yes, absolutely. We've had a lot of patients who delayed for a year, and I think we're starting to see them back in the office. I mean, obviously in our medical practices, we're still masked, and
Yes.
So we're definitely seeing some of those patients now beginning to kind of get comfortable again. Our older patients that are, like they've been 2 years and coming back out. But yeah. So,
well, I'm glad to see they're coming back for sure. And if you guys have not gotten this book, they can order it. I got the ebook. It's an ebook, and you can get it. You can download it. You can get it on Amazon too, correct?
I think so. Yeah. Primarily Kathy's website. Yeah. Which I'm to that.
Yeah. So you can go on to Kathy Reagan Young's website, and you can go onto that and order it, but it is great. It's a funny book. It's well done. And it's a great informational book, like Erin said, to kind of get you thinking and kind of give you some tips as to where this all fits together. And I loved being able to do this with you. I was looking forward to this so much, because there are so many questions, like I laughed about that just being their trainer, I get lumped into the psychologist and the pelvic floor, and I'm like, hold, because I'm going to interview her, but I don't have that answer for you yet. So I so appreciate this interview with you, and I look forward to having you with again and speaking with some of our women and really diving deep into this, as more and more people are understanding the importance of this, and that they don't have to jump to surgery. And I think this is something that is becoming more and more clear as patients' voices are becoming louder, and we're becoming saying like, no, I'm going to do this is safe for me. I'm going to do
Right.
it this way.
Exactly.
So Erin, I so appreciate you coming on, and thank you
You're
for taking the time to do this today.
Absolutely. I very much enjoyed talking with you.
And I will have on the bottom of the show notes all of your stuff and how to get a hold of you. And
Great.
Anything else that you want to add, let me know. Anything that ways that they can get a hold of you, your email, we'll have that.
Okay, sounds good.
And are you on Instagram, Twitter?
I'm not really I have like an Instagram that's really kind of based more for pre and postpartum, pelvic floor physical therapy, mommy care PT.
I wanted to talk to you before we go. I know that was on there. Talk to me about that for our younger moms.
Right. So basically, it's just the idea and the truth of the fact that we don't really do a great job taking care of moms after they have babies. And I think the way that I kind of sum it up is that if you had as much injury to your ankle with an ankle sprain or a car accident or something like that, you would have rehab. But women, basically, we, push babies out. We have 9 months of hormonal changes, physical changes. Our ligaments are stretched and changed and moved. And I kind of, laugh with my patients, and it's not really funny. It's like a sarcastic way. We hand you your baby, we pat you on the head, and we say, don't forget to do your Kegels as you're like grabbing this baby going, I don't even know what a Kegel is.
Right. Or I'm so terrified to even to use anything down there again. And I had 3 kids total, and 2 of them were boys, and they were almost 10 pounds. So I was like, oh, and so I just, I felt like going home, I'm like, wow, that was a lot. And, I felt like my youngest, you could have just fed him hot dogs in the beginning. So to just be sent home, and, I'm tall, but I'm tiny. And so to be sent home and to think that wasn't going to change my body at all was, so crazy.
It is so crazy. And just, it's like, again, it's like, this is a whole other thing, but it's like, it's not just even the birth, which is clearly enough sustained injury, but it's the months. And even if you just look at, okay, the last 3 months, think about how your back and your rib cage and your abdominals and the core that's so
and the separation and all that.
Yeah, you'll be just you'll be.
It'll all go back together fine.
Yeah, everything's fine. Whereas if we just educated, and I'm not saying that everybody needs hands-on care. I'm not advocating that, every person has to have this extensive amount of care. It's more the education. It's more like,
absolutely.
Hey, there are some things that you can do. And these are some basic tips that you can do to then take into the rest of your life.
I love that. So I'm definitely going to have that on the bottom of the show notes, because I want moms to know that. And I touched on that, and I put it in my notes, and then we got talking and I didn't touch on that. So wanted to make sure I touched on that, because I think it's beautiful. And I read that and I thought, darn it, where were you when I had my babies? So love that you do that. So new moms, check that out, because it's so important. So again, thank you for all that you're doing. Love that. And keep up the good work.
Yeah, back at you.
Thank you. Well, it was a pleasure. I knew it would be. Can't wait to talk to you again, and have a great day.
You too. Thanks, Kathy.
Thank you, Erin.
Bye-bye.
Well, thank you so much for joining us today on Move It or Lose It podcast, where you can again find us every Tuesday, and also wherever you like your podcast, whether it's Apple, Spotify, Stitcher. Join us on that, and we can't wait to see you again. We're going to have a lot of exciting guests and working together. And as always, you'll hear us say at the end of every podcast, we are stronger together. So let's do it. Let's become stronger together.